Oh, good evening. Good morning, actually. I'm here in Croatia.
Yeah, we'll just give it a minute here. Yep. Let's see. We've opened the meeting up. Okay, the participants are starting to come in. We've got about 5 minutes before our presentation occurs here. So just like to thank everybody that's joining us today for the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. This is a series of webinars that is being co-sponsored by the University of Washington School of Dentistry CE department. We also have sponsorship from the Canadian Academy of Restorative Dentistry and Prosthodontics. We have sponsorship from our friends at Seattle-King County Dental Society, Pierce County Dental Society, Snohomish County Dental Society. Comet USA has been a supporter of these webinars. We appreciate that. And Patterson Dental. We will also remind you that one of our partners is the University of Washington School of Dentistry student chapter of the American Academy of General Dentistry. As you see your screen there, you'll see there's flyers of upcoming webinars that we'll be carrying over the next few days here. We're going to have 8 webinars this week, and then we'll roll into some webinars next week and continuing on. We don't know how long we're going to be out of our offices here in Washington State, and so we'll kind of just tailor the webinars based on the recommendations of the Governor, Jay Inslee. So if you're interested in any of these webinars coming up, you'll see there's QR codes. Those QR codes can be used to register. If that's not working for you, go to www.washingtonagd.org and you'll be able to scroll down and see our speakers. We're trying to stay up to date as best we can with our website and add our speakers as we get commitments from them and their details. Today, you will be receiving CE credit. Your CE credit will be emailed to you based on the email address you used while registering for this course. So for those of you that are AGD members, your credits will be sent into the Academy of General Dentistry on your behalf. You do not need to submit those, but please don't be looking for those on your transcript anytime in the next few days. It's going to probably take a couple of weeks. With all the CE events that's going on, it's tough for the AGD to keep up with all these CE credits. Just a reminder that Dr. Yassine is continuing with his implant study club, and he's got a special guest, Dr. Steve Rassner. Many of you saw Dr. Steve Rassner present the other day. Did a wonderful job, so that will be a good one for anybody to attend. We get questions whether these webinars are being recorded. Yes, they are being recorded. They will show up on YouTube within a few hours. Right now you cannot receive CE credit for watching those webinars on YouTube. Perhaps in the future we'll have an on-demand option for those that want to get CE credit from reviewing these webinars. Janice Hurley, just spoke with her this morning. She's going to have a nice presentation tomorrow about leading with confidence and how to get your practices back to business as usual. Our friend Dr. Taser Suleiman is presenting tomorrow. You know him as a materials expert. He's going to be talking about 30 years of bleaching and where we're at. And boy, we're proud to have Dr. Michael Fling, the president of the American Academy of Restorative Dentistry, presenting on Wednesday afternoon. So we'll just give a couple of minutes here for everybody to join us. We're going to start at 9:30, and we'll have our introduction of our speaker today. Again, CE credit, is coming from the University of Washington School of Dentistry CE department. Be looking for a PDF from them in the next couple of days. We ask you to save a copy of that just in case there's any issues with those CE credits being credited to your account, your transcripts, pardon me, from the Academy of General Dentistry or your local licensing boards. So it's 9:30 a.m. here in Seattle, Washington. Again, we would like to welcome everybody to the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. We'd like to thank our sponsors, Comet USA, the Canadian Academy of Restorative Dentistry and Prosthodontics, the University of Washington School of Dentistry CE, Pierce County Dental Society, Snohomish County Dental Society, and Seattle King County Dental Society, and also Patterson Dental. For those of you that are not Academy of General Dentistry members, yes, you will be getting CE credit. Those of you that are AGD members, we will be submitting your transcripts or the CE for your transcripts to the AGD, and you should see that on your transcript within a couple of weeks. For you young dentists out there, dental students, just a reminder, in August, we plan on hosting our Crown Preparation 101 course again. This is a course that walks you through seating your patient, the build-up, rubber dam, prepping, impression, provisional, and releasing the patient. It's a nice one-day course to go start to finish on crown preparations and learning some of the thinking skills and verbal skills, not just the hand skills that are involved. So it gives me great pleasure to introduce our speaker today. Dr. Starčević is a good friend of mine. He hosted me in Croatia a couple of years ago, just an absolutely wonderful time. But let me tell you a little bit about him. He graduated from the School of Dentistry at the University of Zagreb in 1993. After completion of his internship, he was employed in the public practice of dental medicine in Zagreb, and he purchased his private practice in Zagreb in 2006. Since 2010, Dr. Starčević is the main organizer of the Aesthetic Dental Moment in Zadar, which is recognized by the Croatian Chamber of Dental Medicine, which supports the Congress every year. He is the founder and president of the Croatian Academy of Aesthetic Dental Medicine, along with many professors and dental technicians. Dr. Starčević is an ITI member, affiliate member of EAED, and editor in magazine Stomatologiczny Poland. Sorry about that. Received many poster presentations awards, such as the 2010 Quintessence Congress in Zagreb, Competence in Aesthetics in 2012 by Ivoclar, and the AAED in San Diego in 2017. He's given a series of lectures and hands-on courses in Croatia, Serbia, Slovenia, Poland, Indonesia, Turkey, Lebanon, Ukraine, and Bosnia and Herzegovina in preparation and indications of glass ceramic and zirconia ceramics in dental medicine and implantology. He was invited to and presented on Table Clinic in Chicago at the American Academy of Restorative Dentistry in 2019. In July 2019, he graduated from the School of Dental Medicine at the University of Zagreb with a postgraduate degree in dental implantology and was promoted to Scientific Master of Dental Medicine. He's translated Linda Greenwald's book, Bleaching Techniques in Restorative Dentistry, into Croatian, and regularly writes articles for the Journal of Dental Medicine and other publications. In his free time, he's engaged in recreational basketball, climbing, to Everest Base Camp, cycling, and skiing. And are you not also a hockey player, I thought? Did you leave that out of your
I'm
bio?
just a hockey fan.
Hockey fan. Okay, we can't all be hockey
Ice
players.
hockey fan. Very big fan of ice hockey, but I am not playing the ice hockey.
Yeah.
I can play for fun, just for exercise, but not anything else. And I have to tell that I'm not president anymore. Since 2018, there is a new one, Joško Viskić, who is new president. Now I'm a little bit retired from the academy, but what you said, all things, it's right. But this is something what's new, and I was president until 2018. Now I'm not the president anymore.
Well, we just want to welcome you and say thank you very much for donating your time to this webinar series, our WAGD Stay Home, Stay Healthy series. It's very, very kind of you to do this. So please, you have the helm. Go ahead and share your screen. And thank you again, sir.
Okay. Good morning, everybody in Seattle. Good evening from Croatia. Just a second to share. I think it's going on. Is it everything perfect?
Looks good here.
Yeah. Can you move a little bit windows by side for me, because it's 4 windows open and I can see about 20% of the screen, because I cannot. Maybe now I can. I cannot see the cursor this time also like before. Okay, let's start. Good evening, everybody. Good morning, actually. Good evening from Croatia. My name is Hrvoje Starčević, as Timi said before. I'm a dentist from Zagreb, Croatia. And today I will speak about non-prep veneers in upper jaw. When the patient comes to my practice, you usually say, oh, doctor, can you just place a little bit, just a composite, something that we have the whole teeth? And it's so simple. It's just take impression, take small chips, put it inside, and everything is finished. So this is not just simple like it's have to be, because there is no preparation, there's no cutting the tooth, there's no other things, but it's lots of work, and you have to do it very precious if you want to do the right job. But first of all, I want to introduce you a little bit myself from Croatia and part of Croatia where I've come. So I will play the small video what is showing what beauty we have in Croatia, and you are all invited to come to Croatia. So let's start with Croatia and the sea and the countryside. This is Nature Theater in Zagreb, museum in Zagreb, art museum, Korčula Island, Marco Polo City. This is the letter C in Glagoljica, old letter in Croatia. Arena Pula, one of the oldest near the Colosseum in Verona. It's just my practice, nothing else. This is Diocletian Palace in Split, from the Roman Empire, 300 in the beginning of this. Castle St. Nicola on the entrance of Šibenik. The lighthouse on the Long Island on the Italy side. Beautiful islands in Croatia. Zadar, the city where the Congress was and still is, where Timi was here, there. My wife working in practice. The cathedral in Šibenik, the old Šibenik. Beaches on island. National lakes, Plitvica Lakes, National Park. The continental part of Osijek. Istria Park, Motovun, Bela Luka on Korčula Island, Long Island with National Park Kornati, National Park Waterfall Krka near the Šibenik, Golden Horn on Brač Island, and the cathedral, which is actually destroyed in the earthquake that we had a few weeks ago. And you also know the Dubrovnik from the Game of Thrones, the Robin Hood. And if you didn't know, the homeland of tie is Croatia. The first people who started to wear the tie was Croatian people during the war in Sweden. And we tie the scarf around the neck, the red one that we show ourselves. And that's how the story of tie starts. So also the Croatia is very popular, very famous about these things. Oops, something stopped. Is everything okay? I cannot see anything. Can you help me?
Yeah, no, I'm not hearing anything. Is the video done? Now you're going into your PowerPoint?
No, the video was PowerPoint. We tried before and everything was working.
Okay.
Let me do it from the escape and start again. Okay, we can continue like this. Okay,
All righty.
You all know Croatia about World Cup 2080 when we were second in the world. And this is Hrvoje Starčević after the semi-final when we come to the final. That was a big success for us because then all the people know where is Croatia and how many people live here and how so many people become a vice champion of the world. So we are so proud of this, about our national team. As I said before, we had the earthquake in Zagreb a few weeks. So it's a little bit destroyed now, but as you see, cathedral is decapitated with and some things is broken, but we are fighters and we will keeping on. So let's continue with dentistry. Let's continue something with what we are here. So what is our main goal about veneers and what we do? What is the reason that we do the non-prep veneers? Because the reason is that we want to excellent aesthetic results and not to touch any biological structures with this. And how we can do it? We are preserving the enamel because when you are cutting through the enamel, you come to dentin, it is not more veneers as most people say, because the enamel is, you have the much more connecting with the enamel, 2 to 3 times much more powerful connecting with the tooth and the prosthetic part than you have the dentin and the enamel. So we have to keep everything in enamel, especially if we don't touch anything. So this is minimal invasive restoration and possibly the highest bone strength between the tooth and the prosthetic part. So what is advantage and disadvantage of all this? There is tooth tissue preservation, no preparation, no post-operative sensibility. We can do the high quality restoration and perfect harmony between the soft tissue and hard tissue. And after that, we have to satisfy patients. And disadvantage is because if you have some undercut there, you have to smoothly do the preparation about that undercut because the non-prep veneers cannot come up if there are undercuts there. Sometimes can be over-contoured because not all the tooth are in the ideal position. So you have to take care about how thin or thicker they are. And the problem is also during the cementation, it's very fragile, so it can be broken or fractured. So, and it's impossible to color all the discolored teeth. And that's the main problem of this. So if you're going further, we can split that in a few phases. The first phase is phase 1, when we plan and build up everything. So what we have to do, the first thing what we have to do is take the photos of the patients. What is important to take the photos of the patients? Take several photos, so many photos, and smile when speaking, when everything, because then you get lots of information what you can send to the dental technician, because most important thing is that dentists are not alone in this part. We are teamed together with the lab. We are teamed together with the dental technician, and there is not just me who is in charge for everything. Also is dental technician, and the correspondence between the practice and the lab is most important things. And if it's some misunderstanding between them, there will be no result. So first, we have to do lots of photos, and then we can go further. Then we can do what? We can do impression. How we can do impression? What material we can use to do impression? So you have to take the metal tray, especially if you have the rim lock metal tray, and make the one-step silicone impression for the upper jaw and the lower jaw. And then I do the bite registration in aluminum wax. Maybe you can do some silicone, which is specialized for the registration. And if you want to try to do with polyether, that will be very difficult for the dental technician to take the model outside of the polyether. If you take the silicone, it's not so good. If you take I heard one lecture before, it was one colleague who said that he took by the hydrocolloid. It is very difficult to do impression with hydrocolloid. So the first choice material for me will be PVS or polyvinyl siloxane, silicone, how everybody call that. So you can see the impression, how it looks like. On the left is in the metal tray, on the right is the plastic tray. So you can see down there, there is an article about what is the difference between that. But I took the plastic tray because it's just the opposite jaw, for the lower jaw, and the main impression was for the upper jaw, when we have all the details what we need for the good result. Also, as a dentist, we have to use the phaseball. The phaseball is very important because we are sending the information to the dental technician that he can place the model in the articulator, and he have the position of the upper jaw with this, and he have all information what he needs, that he can do the right job, and he can test the movement in the models, and then we will not have the fragile of the veneers after that, and we have good result. Even you can see from 1953, there is a article about phaseball. Since then, about 70 years ago, the people realized that it's very, very important that we have the phaseball registration, that we can use the right position of the upper jaw. So now what we are doing, we're doing the digital smile design. We start with Christian Coachman and Marcelo Calameta, my dear friends from the Brazil, from Sao Paulo. And the digital smile design show us, and we can show the patient how it's going to look like just by the photos, without impression, just with the photos and everything. We can do the digital smile design, and patient can see how it looks like after that. The tooth color, it's also important that we choose the right tooth color. I'm not paid by the Vita. Unfortunately, we also use the Vita key for the Vita shade here in Croatia. And most of the technicians like this classical one. The gray color on this K is because after 5 seconds, if you look at more than 5 seconds in the color and the tooth, you can, your head is memorizing that color, and you are not able to recognize the difference between the colors. So the gray color on this is because you can reset your eyes, you can reset the brain, and then you can choose the color again, because if you're going to choose, you will have the chameleon effect in your head, and you will be a little bit messed up with your head, and maybe the color what you show the technician and what you send to the technician maybe won't be the right one. After that, there was the master guide, tooth guide, linear guide, and even that today we can do it digitally. When we send to the dental technician the impression, he did the model. He did the model for the plaster, and after that, what he did is wax up. Today it's possible also to do the scan, and to do the scan with the computer, to do wax up with the computer, but I'm still the old school. I like the wax up directly on the model, because I think that 3 days not so precious today. Maybe will be in half a year, 1 year, 2 years, but because I'm a little bit older, I still like the old school, and this model can help me that I can do the guidelines over this, and some impressions for the temporary works. Why temporary works? So this is the difference between wax up and how the model. So now we have the wax up. So when you have the wax up, you make the impression over it, and you can take with the transparent silicone. This is one case when I use the transparent silicone and put the flowable composites inside. And then I show the patient how can be in her mouth. And she was very satisfied. Then I continue with this work. Other thing, when you have teeth like this, also you can do with a temporary provisional material, but you have to cut the space between papilla that the materials went out from the silicone, and then you cut just with a probe. You just move it on, and you have the perfect situation after that. Then what you do with when the patients have that in that mouth, you check occlusion in the mouth. Is everything correct? What the technician did in dental practice, and what you're going to do? Because if it's problem with occlusion, you will have lots of problem, and you will have fragile of the veneers, and it will be broken, and then you have to do it again, and it's much difficult to work it again than you work it in the first time for the technician, because when he's working at the same time the whole mouth, he can do it better than to find the right color, the right amount of the ceramics and everything and colors, because he always mix something with the other color, and this is the perfect way to do it all at once, not part by part. And also you have to do the phonation, check the phonation with F, with D. You have those from Academy in the States, which is based on this, and I don't want to speak now about all that, but when you have the provisory in the mouth, you have to check everything, and if you have some problem, you have to tell the technician where you have the problem and make the mark, and the technician will have all the information what he needs. Then comes phase 2. The material what we're going to use in mouth. For the non-prep veneers, my first choice is feldspathic ceramic, but also it can be worked with lithium disilicate and zirconia oxide. What is the difference? Feldspathic ceramics is a glass bind system, mainly with silicon dioxide, and the flexural strength can be 120 to 150 megapascal, and it have chameleon effect, and it's possible of etching. And what is most important, this part can be very, very thin. What we can see on future slide, where you can see on the left one, it's less than 0.1 millimeter. In the cervical part, and also in the incisal part, it's about 2.5, and I think it's 3.5. Yes, 4.5. Sorry, 4.5, because there are a lot or others, and it's very thin. So we have to work with this very carefully that we don't broke this. After that is lithium disilicate, which is material, my choice of material what I use when I have the preparation. Why is the preparation this is glass-based system with fillers and lithium silicate, aluminum silicate glass, and much power strange than the feldspathic ceramic. It's about 360 up to the 400. And why when it's preparation? Because this material can be veneered with special porcelain, and also possibility for etching it. We have better connection between the tooth in the prosthetic part. And but when you use, also there can be thin. On the left side you can see about 0.1 and 0.4. It's very good, but for the non-prep veneers I will rather use the feldspathic ceramic. Zirconia is very popular now because you can work with a CAD CAM, but I don't like zirconia. It's a very good strange for 600 with a cubic now for the 110 with this all one. Also can be veneered, but there's no etching possibility, and you cannot go. There is few articles which is said that can be etching, but I don't believe, because zirconia is in the chemical system just below the titanium, and it's still part of the metal part. So I think it's much better connection with the tooth, and the prosthetic part. It's if you have Feldspathic veneers and lithium silicate, and for the zirconia I will use for the full crowns, and especially monolithic zirconia now is very popular. But you can see it's a little bit thicker than other one, and sorry, this is not Corona, it's just dry throat, and it's a little bit thicker one, and that zirconia was made by the CAD can. All other was made by the ingots or directly pressed on the plaster. And then we come to the phase 3. Phase 3 it's adhesion. And this is the phase where we have to be very careful. This is the phase when what all we did with this material can be destroyed in 1 second. So this is time what I don't like the most when I'm doing the non-prep veneers, because sometimes it can be a few hours to cement just the 4 veneers in one job. So you have to be very careful, and you have to go very slow. So first we have veneers. We can see here the 8 veneers. And then we check in them out. And all the veneers have to be very nice, that they have to be very precious on the tooth. You can see the borders now. You can see they are lighter than the tooth now. But when you bond the veneers, when you bond the tooth, when you put the composite, I'm using the flowable composite between the tooth and the veneers, the color will be almost the same. But now you can see the difference between the color. So how I can do this? When I checked, I put on the micro brush, and I use the dam barrier to glue it directly. Sometimes I use the sticks, which is stick from Ivoclar, that small pieces. But sometimes I can use with the fingers. But when you have some veneers like this, the best part is to use the dam, and you can cure it. And after that, you have in the right position, and you can manage with that how much you want. And it wouldn't fall down, for sure. And then we treat veneers with a hydrofluoric acid for 120 seconds. And after that, we also etch with the orthophosphoric acid for 10 seconds to remove the salt from the surface. Also, we silanize the veneers. This is a very important part of the cementation. What is silanization? The silan group is coming to the group of compound containing the silicate atom, and it is made from 2 parts, organic and inorganic. The organic part is the connection to the adhesive composite, and inorganic part is connection to veneer, and it is inorganic part. And both connections are covalent connection, and this part of silan will give us a more strange and much more connection between the veneer and the tooth. The most important things is you have to use the new one, and the best thing when you're using the silan, when you use a single dose of silan, because if you're using from the bottles, after about 10-15 days, a month, if you open all the time, the function of that silan will be not the same, because the alcohol went out, and there will be there will be not the same material anymore. So you have to buy a new one. So if you can just buy a single dose, it is much more better, and you will have better result with this. So the cementation part is that place retraction cord if you need it, and protect the other tooth, and then inflict the adhesive agent in tooth and veneer. Now we come to the very problematic part, and it's cementation. So when we put what I said before, I'm using the flowable composite. Usually I use the A1 color because most of the people who have the intact tooth are the younger people and have the lighter teeth. And when you have the older people, maybe you have some destroyed by the bruxism or other things. And this is not more the same things when you have no untouchable teeth. Let's call that this way. So we put the flowable composite. Why not? I'm not using the technique with the base and the catalysator. I'm not using that, but catalysator is always the gray color. And if you put inside the gray color, will give you other color of the tooth, and you will have real problem. And then the tooth will become a little bit gray. So because it's very thin layer, the light can go through the veneers, and you can light cure the veneer very, very easily also with the flowable composite. Also it's better if you put the flowable composite in the heater before on 55 degrees, then it's more flowable when you heat the composite before, and then you have the better result. So then you press a little bit, then you light cure for the 2 to 5 seconds, and then you have the primary stabilization of the veneer and the primary starting of the hardness of the composites. And then I use the blade number 12 with the double sharp on the sharp of the both side, and I cut this part from the veneer to the tooth, and it goes very slowly, and you have to follow the shape of the veneer to the shape of the tooth, because if you go to the other direction, you will have the undercut and you will destroy everything. So just movement in one direction from the veneer to the tooth. You cannot go other direction because you will destroy the whole thing. And this is the main problem in the whole work, how to cement and how to fix this part. This is the main goal, the main problem, where everybody who is not good in this fell down. All other things you can control, but this part you can control only if you're doing it real slow and when you know what you're doing. You can see the final result. You can see how wide is connection between the veneer and the tooth. You can see that I also cut a little bit the tissue, but it is just the small damage of the tissue, and it will be finished about 10 minutes after it will be healed. But the main thing is that we have the nice connection between the tooth, veneer and the tooth, and very wide. And then we have, you can see after in the cases, what I show you now, how it's going to be after that, the similar case in which you saw now. So let's forward to the cases what we have. This is that case with the left canine, and in the beginning on the left side you see the canine is shorter, and other dentists recommend to the patient we can prepare, make a crown, we can do with composites, we can do everything, and I present her how we can do it with the non-prep veneers. We don't touch the tooth. We will just take an impression, and after that we can just glue a little part. She asked for sure why it's so expensive, because it is very expensive, because it's very hard to do it on the right way, what I showed you before. So the technician made the models. This one is Geller, and he did 2 veneers. Why he did 2 veneers? He did 2 veneers in the reason because if one is not good, if one is broken, immediately I have another one. So I choose the better one. This is 1 and 2 from one side to that another side. I choose the better one. I treat the tooth. I put the Teflon around to protect the other tooth. This is how tooth looks like. Then I put the bond in. Then we clean the surface, inner surface of the ceramic, of the veneer of Feldspathic, and prepare everything. Then we press, you saw that before. And now you can see the final result on the right side. You can see the final result from the other side. You can see when you look much more closer, you can see the difference of where the bond is. But when you look in the mouth from the talking distance, you cannot see. And then you feel and then you can see the final result. We're not looking for the other teeth because the patient comes only because of that teeth. And you can see the situation before and after. And it's much difficult, and we didn't touch the tooth. That is what is when you mean non-prep. We didn't touch, we just clean the surface, and then we do the crown up there. The dental technician who did this is Hrvoje. The other patient came. So what we did first, we did lots of pictures. Frontal from one side, another side, and she was not satisfied with the second incisor. So he made a model. Then he prepared the veneers. As you can see, the veneers didn't cover the whole tooth. It covered just the half part, because that was the reason what I said before. Someone can be over-contoured. It can be bigger. So we have to be very careful with these small chips when we plan everything. So he did in this way. We prepare the tooth, we etch the tooth, we etch the chips on the both sides, and this is tooth from one side, and this is tooth from another side. We use the Flowable composite, light cure. And then we have the final result. If you can see the right one, you can see in the middle the line, which is not straight line. It can be better if it's a little bit curved. Then the people can be not able to see the difference, to see the border. Because if you put the right line, you will always see the border. But if you can do a little bit curved, and that will be a little bit smoothly. Then you cannot see the difference between. Also on the right one, you can see, this is directly after cementation, you can see just a little part on the incisal where is the veneer a little bit over contoured, which after that I was correct. And yet now you can see the final work in the mouth. What is most important, takes few years, and the patients come all the time. And this is how it looks 4 years after. There is, from the talking distance, maybe now when you know where the veneers are, when you know what we did, you can find where veneers are. But I don't think that you find on the right lateral incisor that you can see veneers. On the left, you can see, because the veneers on the half, you can see just a small line. But I think this is amazing result 4 years after it. And we didn't touch the teeth. We didn't prepare anything on the teeth. Hrvoje also did actually Hrvoje finished the master from the UCLA in the States 2 or 3 years ago. So now he's working in Croatia, but he also was in the States when he was specialized to master dental technician. There comes another patient. This patient came because she was not satisfied with her incisor. And many people will do just the veneers on the frontal incisor. That was the case what I showed you before. And then when he put on the model, he called me and said, we have the problem, because I also have to do the small chips on the canines. Because if I do just the incisor, the frontal one and the lateral one, we will have the bigger one on the lateral, and the results will be not good. The aesthetics will be not good. So he did this way. You can see how small are these chips on the canine. And we didn't prepare anything on that tooth. You can see transparency from this material, that you can change also the color with the material which you use for the bonding this material to the tooth, because every time when you use the material, because of the thickness of material, you can change the color. This is most important, that sometimes if the color is not so good, you can change the color, and also the veneer have the chameleon effect, so after few days it will become not visible for the other people that there is any prosthetic work what we did in the mouth. So first we probe in the mouth, do the check-in, how it is. Then we have the final work, 6 months after. This is how she looks 6 months after. Unfortunately, I cannot making discussion with you. Usually you have the people in the room, so you can make discussion, but now I cannot hear you what you mean about that. But if I know where the preparation is, where the veneers are. I know everything, but I don't see any difference between the veneer and the normal tooth, what they are. So that's for me is perfect work. She's wearing that half year, that don't have any problem, and she's very satisfied with this. Dental technician was also Alan Alic. Now we come to one case which is for me very special, because this is daughter of my very good friend. Unfortunately, he passed away a few years ago. And when she came first time, she was 16 years old, and she didn't satisfied how she looks. And actually, this is genetics, and her mother and her uncle have the same teeth. And you can see on the lower incisor the result of the deep bite and everything. So she decides, I want to take care of this. I want to change my view. And at that point, I suggest her to do orthodontic treatment. And she didn't want to wear the wire for the 1 or 2 years. And then we said that let's wait a few years after you wouldn't be developed all the mouth, for example, 2 or 3 years, and then we'll see what's happening. Meanwhile, you have to be like this way. What she accept more than she accept the orthodontic treatment. And what we find, this is what we're trying to do, this is how we did. What we will have to do, this helped me with the Marcelo Calamita from Brazil. He sent me that at that moment. And I didn't know what to exactly do, because nothing was in the right position. 3 years after, we have a totally different situation. We have different situation because we wait, because we didn't push something that we have to do today, tomorrow. There is some situation in dentistry when you have to push something and you have to do it immediately. But sometimes it's also good to wait, because now we have totally other situation. 3 years after, we have situation that we can do a lot. So we did the pictures all around. We did examination, we did the impression. We did a model, we did a wax up, and we did veneers. We probe veneers. Then we treat the veneers. How we treat? You see, we can light cure. When light cure, you can almost do whatever you want with this. So it's not a problem. You can see when you rinse the hydrofluoric acid or orthophosphoric acid, the veneers are in the same position. And you don't have the problems to movement of veneers. And then we start with bonding first incisor. Why we start with the first incisor? If you start from the side, from the premolar side, sometimes when you come to the frontal part, maybe you wouldn't be in the right position. And the right position of the central incisor is the most important position. So you start with the central incisor. Then we move forward. Now you can see through there is the blue color of the orthophosphoric acid, but you can see also the blue cord inside, which I put to move a little bit the tissue, that we have the more space, that we can glue it perfectly in the mouth. So we glue it, and you can see from the first premolar to another premolar, you can see all veneers. It is just after what we did, and it looks like this. Maybe here you can see the difference between veneers and the tooth, but truly from the talking distance there is no difference. The most important thing is patient satisfaction at the end. And some things what you can hide, the impressions that somebody is very satisfied with what you did. And I think this is most important thing why we are here in practice, why we are working our job, to make the patient satisfied. And they can smile all the time. And this is the reason why they come to us, also to cure them. And we can see now situation 1 year after. You can see some other things, but I didn't clean it because that you can see that it's 1 year passed after that. And how it looks, still perfect. This is 1 year after. 2 years after. In the meantime, I cleaned some calculus and tooth.
All righty. Did we lose our presenter? We did. Okay.
Yeah, I'm getting nothing, Tim.
Okay. So I will hold on, everyone. We will, I'll just WhatsApp him and have him log off and log back in. Wow, we were doing pretty well there with the connection from Croatia. Dr. Hayamoto, would you just talk about the Q&A there again for us there?
So, oh, there you go.
I'm here.
Hey, beauty. All right, go ahead and share your screen again.
Otisci za studijske modele. Na uslovu tih otisaka ja sam izradio studijske modele i izradio individualnu žlicu za definitivne otiske. Na taj način dobili smo jako precizne definitivne otiske.
Not sure whose voice that is.
Kojih sam izlio modele i napravio oboštanu dijagnostiku stvari.
Val, can you
You can see?
kasnije služila za...
We can see you. We just can't.
Yeah, I'm looking for it. Hold on just a second, Dr. Hess.
Okay, thank you.
Can you see us?
We can see you. We just need
you-
your
Did you
presentation.
see the video?
Nope, we can't see the video.
You see me and you cannot see the video.
That is correct.
There is some problem with the video, but before the video you saw everything.
That is correct. Yeah.
Let me-
Sometimes videos just overwhelm the system.
Okay, let's do it. Share again. Okay, now you can see.
Yeah, terrific.
Dr.
Perfect.
Hess, I'm spotlighting the video, so we should be able to see that now.
Okay. It's
Beautiful.
perfect now.
Thank you.
You're welcome. Sorry.
Canine slučaj je jako zanimljiv slučaj. Znači, radi se o mladoj djevojci koja je trebala rekonstrukciju osmijeha. Više manje radilo se o zatvaranju dijastema i promjeni oblika zuba. Prvi neki podatak kojega sam dobio su otisci za studijske modele. Na uslovu tih otisaka ja sam izradio studijske modele i izradio individualnu žlicu za definitivne otiske. Na taj način dobili smo jako precizne definitivne otiske u silikonu, pomoću kojih sam izlio modele i napravio oboštanu dijagnostiku, u stvari neku oboštanu maketu, koja nam je kasnije služila za neku komunikaciju sa pacijenticom i meni sa doktorom u vidu da li je oblik ok, da li je funkcija ok i na uslovu toga poslije izradio sam silikonske ključeve unutar kojih sam usvojio keramiku. Pošto se radilo o intaktnim zubima i u stvari non-invazivnom pristupu rekonstrukcije tog osmijeha, moj izbor materijala bio je staklo keramika. Staklo keramika se može nekako najljepše uraditi i može se uraditi u najtanjem mogućem sloju. Znači puno tanja nego ostale alternative u vidu pres keramike ili u vidu CAD-CAM tehnike. Staklo keramiku je moguće uraditi i CAD-CAM tehnologijom, ali ne tako kvalitetno kao što se to može manualno.
Sorry. I have to do. We have a problem with this video, but I want to show the video. Let's do it again. Third time is lucky time. Not touching anything, just hand above the head and waiting. Sorry about that.
Canine slučaj je jako zanimljiv slučaj. Znači, radi se o mladoj djevojci koja je trebala rekonstrukciju osmijeha. Više manje radilo se o zatvaranju dijastema i promjeni oblika zuba. Prvi neki podatak kojega sam dobio su otisci za studijske modele. Na uslovu tih otisaka ja sam izradio studijske modele i izradio individualnu žlicu za definitivne otiske. Na taj način dobili smo jako precizne definitivne otiske u silikonu, pomoću kojih sam izlio modele i napravio oboštanu dijagnostiku, u stvari neku oboštanu maketu, koja nam je kasnije služila za neku komunikaciju sa pacijenticom i meni sa doktorom u vidu da li je oblik ok, da li je funkcija ok i na uslovu toga poslije izradio sam silikonske ključeve unutar kojih sam usvojio keramiku. Pošto se radilo o intaktnim zubima i u stvari non-invazivnom pristupu rekonstrukcije tog osmijeha, moj izbor materijala bio je staklo keramika. Staklo keramika se može nekako najljepše uraditi i može se uraditi u najtanjem mogućem sloju. Znači puno tanja nego ostale alternative u vidu pres keramike ili u vidu CAD-CAM tehnologije. Staklo keramiku je moguće uraditi i CAD-CAM tehnologijom, ali ne tako kvalitetno kao što se to može manualno uraditi. Znači princip CAD-CAM tehnologije je sasvim mašinski, znači to se frezuje iz nekog bloka, dok se način koji sam ja izabrao radi na način da se keramika sloje na vatrostalne patrljke. Sa tim možemo dobiti jako tanke strukture, čak od 0,25 mm. Sekcionirani radni model se dublira, znači svaki patrljak posebno se dublira u silikonu i onda se izliju posebni patrljci iz vatrostalne mase. Kasnije se ta masa sinterira, da se vrati u dimenziju koja je identična dimenziji originalnih patrljaka, onda se na toj vatrostalnoj masi direktno sinteruje keramika. Dužinu zuba na neki način, koliko god sam mjerio i koliko sam analizirao osmijeh i lice pacijentice, na kraju sam odlučio da ne diram dužinu jedinica, mislim fronte, pošto je i zagriz bio jako dug. I bio sam na neki način ograničen tim kretnjama i vođenjem bočnjaku, tako da dužinu nismo dirali.
There is a whole video, about 10 minutes, you can find in Croatian language, but with subtitle in English. You can find it on Facebook, on Dental Practice Starčević. You can see it here. And thank you for your attention. And if anybody wants to ask me, they can send me the email on hrvoje@drstarcevic.hr.
Thank you, Dr. Starčević. That was wonderful. We'd like to do some Q&A with you, if that's all right.
No problem.
I'll read the questions to you.
If I didn't know, I would just escape.
No, you don't just escape here.
Oh, we have a connection problem.
Okay, we'll try and group them together, but thank you again. With the Washington Academy of General Dentistry and all our co-sponsors.
Thank you for the invitation.
You putting the effort in.
My pleasure to be part of this.
Okay, can you please explain again what the strengths of feldspathic ceramic versus lithium disilicate materials are and their main differences? Thank you.
The strength of the feldspathic ceramics is from 120 to 150, even less, even to 90. And the strange, because the lithium disilicate and alumina parts in the Emax or lithium disilicate, it's 360 up to the 400, 420 sometimes. And it's much bigger. And when you using the feldspathic ceramics, it's very dangerous because sometimes if you press, because until you glue it, until you bond it to the tooth, you have a big problem. If you press too hard, it can break. One tooth, when we fixed all the 8 tooth, was broken, so we had to do it again. So this is the main problem with the feldspathic ceramic. But instead of the lithium disilicate, which is material which is what I usually use for the crowns or the prepared veneers, when you prepare veneers for the 0.5, 0.8 on the incisor part, I use the lithium disilicate then, because it's much easier, because you can do the extra porcelain on it on the lithium disilicate. You can cover it, but with this, when you need so tiny slice of the material, for me it's much better to work, and it is very dangerous because of the structure of it. I don't know what anything to say about that. It is just the structure of the lithium feldspathic and the lithium, it wasn't the same, but because the lithium disilicate, they improved lithium disilicate, it's just aluminum, and it's much more strange in that. If it's okay with...
Okay. Sorry, I was going to move to the next question there.
Okay.
We've got about 17 questions here. So if you don't have digital smile design and you have the lab fabricate the veneers, where do you tell them to end the margin?
If we don't have the digital smile, we have dental technicians should know it, because dental technicians should when can put the articulator, they can see relations between the two. They can see the margins when can be, and especially with the feldspathic ceramics, because as I show you in my cases, it cannot be at the end to the tissue, up to the tissue. It can be shorter, and you make just that connection between smoothly. So dental technicians have to follow the shape of the tooth. So because of that, following the tooth, because they know morphology of the tooth, they will know where to finish the tooth. This is how I work with my dental technician. I send him the impression, they send me what they can do with the wax up, and then I say I'm agreed, and then we do the silicone key, and then we try in the mouth, and it is satisfied because it is not too big, not too small. If it's in good relationship with other teeth, what we have in mouth, then we make decisions to go further.
Okay.
Not before.
What are you using to adhere the veneer on the micro brush?
When you go to dental whitening, you always have the silicone dam what you like here, and I put that dam on the light and on the micro brush. I put on veneer, and then I show that on video, and it is, for me, it's the best thing to fix the veneer, and that you can manage with veneer and put it on the tooth. Because when you use from Ivoclar, that's sticky sticks, that is a little bit sticky, and sometimes it's a little bit movement, and but with this you have the hard connection, no movement, and you can easily remove with the blade. After that, you just take the blade and just cut it, and that's it. There is no more material on the veneer. You don't need to clean, just a small movement with the blade, and everything is done.
What instances would you select to do orthodontic treatment versus non-prep veneers?
Oof, this is a very good question. This is very good question, and because what I showed before, I didn't want to work non-prep veneers until the development of the jaw didn't finish. So sometimes you have, with orthodontics, put the teeth in the right position when you can treat it further. But what we did with the non-prep veneers, when we have the smaller tooth, what we usually have to, when the relations, we all know that relations between high and the wider of the tooth is about 75 to 80%. And if we have, for example, tooth what we had here, when it's 60% of widening, the tooth are wide about 60% across to the height, like the Stephen Chu have the key for that. And if we make with orthodontics, we don't have the nice smile, we don't have the good result, and maybe we will have also the problem with the roots up there, because we have to also, with orthodontics, see all the X-rays, the panoramic X-ray, and then we can make decisions, shall we move or not to move, what is the position of the roots. And this is not just, oh, I can use the non-prep veneers, I can use the orthodontics. This is a little bit more, you have to do more examination. So sometimes I can use the orthodontics treatments before, but usually non-prep veneers is used when you need just to build up some small parts, or when you have the diastema, what we have in 2 patients that I had here.
Okay, thank you. If margins are supergingival, do stains develop over the years?
We can see on that patient what I show after 4 years, where the margins are in the middle of the tooth. So this is supragingival, and you can always, when you look carefully, you can always see it. But what is most important, did you see that on the talking distance? Did you see that when you speak to each other, and is the patient satisfied? Because if they clean very well, it can be up to the 5 to 10 years and without problems. And after that, we can discuss about things, other things, about 10 years after. But most of all, there are patients who have about 18 to 20 years old and up to the 25, because after that, for me, is to do the non-prep veneers, it's not so common. You can do that when the patient is younger. After that, you have the problem with the teeth because of attrition, abrasion, bruxism, other things, and you always have to build up a little bit, and you always have to preparation a little bit. This is other thing what we can discuss how much we can cut the vestibular part, that we can prepare the right. But this is discussion for the hands-on some course. But here, I think that the people up to the 30 can do the non-prep veneers. After that is very difficult, and up to date 10 years, I think it can be in the mouth, and you will see not a big difference between the veneer and the tooth.
Okay. Where's the margins for the veneer? How is it wrapping around the incisal and interproximal contact?
This is the biggest problem. The biggest problem of how to manage it. And this is the reason why sometimes you have to do 1 by 1, because in that position, you can glue it in right position. What I show you, I use the blade very, very careful around it. And then I use the interdental strips, but only in one position. I do that just in the position from the veneer to the tooth background, not in opposite way. So just in one position that you can smoothly cover the part to the palatal part. If you're doing in the other position, you also may have the undercut. And this is the most difficult part of this job. This is why this job is so expensive, and you need to practice that. And the margin line is finished when you can put the veneer without any problems up to the tooth. So when you don't have undercut, then you put the veneers. If you have the undercut and you cannot put the veneers, you cannot do that. You just glue it and then push around the tooth and have to do very precision, so, and gently and slowly.
How do you manage occlusion with these cases? I noticed some of the cases, canines and laterals are tight and can interfere in excursives, especially lateral intrusive movements.
The first guy who do that is dental technician, as we saw in the video. This is what we do. The second time, what we do on the provisional, we check the occlusion. The third, what is most important, usually when you have non-prep veneers, non-prep veneers are on the vestibular part, not on the palatal part. maybe on the canine, sometimes you have it on the palatal part, but you can also, when you bond the chips on the canine, for example, and you have to cut a little bit from this side, you're always going from the veneer to the tooth, and you have to ask the patient when he feel the contact, he have to stop. He cannot to press hard. You have to explain to them before when you start to do this. If you don't then explain, maybe you will have the failure.
Okay. How long does the patient wear the smile design?
Sometimes I put it in the mouth and he went home with this, and maybe until it's broken. Or sometimes we broke it directly in the practice, because it wouldn't change anything. It is just to show the patient how it's going to look. Because sometimes patient want to feel about hour and two, but after that it's broken, especially if it's from the temporary material, and you can take it off with a finger. But you have to explain very carefully to the patient. And I ask the patient, would you like to wear it for an hour and two, and maybe one day, depending what will be. I don't know what will be because of your habits. Maybe during your eating, maybe you bite a little bit stronger than I think, and so many things. What can be. But sometimes I take it off in the mouth in the practice, and sometimes if I use the glued composites, I can leave it in the mouth for 2 or 3 days, and then the patient can see if something's broken, and then we can see also the movement and everything, and did we do everything in the right position. This is most important. But depending on the patient, depending on situation, depending how many tooth we have.
Okay. How do you polish the margins for facial excess, and what are your finishing steps on veneers?
From the vestibular part, first I cut with the blade. Then I polish always from the veneer to the tooth, and there is rotation polishing from 3M what you can use, but always in position. You never have, you cannot go in the other direction. You always have to go from the veneers to the tooth, and just follow and follow and follow and follow and follow and follow, and just be patient. There is no other way to do it. Just take a time and do it correctly, because if you do something faster, you will destroy everything and you have to do it again. So just to be careful and go very slowly. Just patient, nothing else. And always from the veneers to the tooth. And I finish with that rubber, sometimes with the pests, from 3 micron to the 1 micron. I have that from Mysterium, so I put some past on it, and then I do it with the past. They have also the diamond pearls inside, and they polish very well.
Okay. What material is used to isolate adjacent teeth at cementation?
Just a plumber wet Teflon, if you ask them that. You just go to the first shop and buy the cheapest plumber Teflon, just put it on, because you can stretch it very well, and there is no problem for the thickness, because it's very thin and they can go all around the tooth.
If dentin is exposed, do you change your adhesive protocol or change treatment plan?
If dentin is exposed up to the more than 30%, I will suggest to make the crown. Because in my 25-year-old experience, when you have more dentin, you have less connection. So maybe it's better to do the crown instead of the veneer if you have that. Also, some people usually have some fillers all around, and it is because some fillings in the proximal part, and it is also the part which is making that connection lower. And but when you work with non-prep veneers, when you work with veneers, and first what you have to do the mock-up. When you do the mock-up, you do the APC, what the Galip Girel said, and then you cut through the temporary material. So you don't look the tooth, you look the final result, and then you're doing preparation to the temporary material. And after that, when you did the preparation, you see what left. And then you control how many enamel, how many dentin is exposed. But what I tell before, if it's exposed more than the 30%, I will do rather the crown than the veneer.
Thank you. This must be somebody that got on late, but what is the procedure for zirconium bonding, and how do you treat teeth and veneers in that case?
Veneers, I'm not doing with zirconia. First things.
Yeah.
I'm not the fan of the zirconia because zirconia is very fragile, especially the new one, which is 600 megapascals, the cubic one. And they did it because transparency. And zirconia is good in some situation. For me, zirconia is best choice material for the implant abutment because zirconia have very good connection with the desmosomes in the tissue. This is very good, not to glaze, just put the zirconia, you will have very good connection with tissue. And zirconia is very good when you want to do the monolithic zirconia in the lower. But when I'm bonding the zirconia, usually I work with a glass ionomer cement, and for me it's maybe the best choice to work because what I use zirconia is for bridges and when people is allergic to metal or metal ceramic bridges or something like this. And in posterior part I like the work, but in frontal part I don't like zirconia. I was the first one who did that in Croatia. It was 2004 when we did the bridge from zirconia. The bridge is still in the mouth, but after that I have lots of things what we learned through the zirconia and how to develop the zirconia and how it, today zirconia is very popular because dental technician can do it very, very fast. And they just put in CAD cam and the machine did and just put it out, a little bit polished, and that's it. If you glaze the zirconia, the problem with the glaze zirconia, the glaze will be destroyed in the 1 or 2 months. And you will don't have the very polished part. You will have something what we call like a strip, what they have the small pearls. We call that here from the German word. Schmiergel from the German words. In Croatia we call that, but it will be cut more the opposite, the antagonist teeth.
Oh, okay, yeah.
Zirconia, the glaze, when it's broken, it starts cutting the opposite teeth, and then you have the other problem. So zirconia have to need to, but the question was with which material. I will use the glass ionomer material for the cemented zirconia, and I will never use zirconia if I don't have to use in frontal region, except for the abutment for the implant, and never use for the veneers because connection is not good and you will be failure for sure in few months.
Okay. What are the instructions you give post-op, and do you have your patients use night guards?
Sometimes night guards is very good solution because they have to wear night guards, especially if they have abrasion teeth, if they have a problem. But when you see the situation before, most of the part you will know is there a problem. So we are talking about young patient. We're talking about patient that HANA patient have the, you can see it on the lower incisor, the deep bite, and you can see how the enamel was a little bit smoothly destroyed. But most of the people have, we put in the right position what we have before. And maybe we have a 2 or 3 tooth, maybe we have just a frontal tooth. So most of it, there is no problem. But if you have some problem, if some veneer is broken, I suggest to use the night guard after that people can, because some people don't know what they do through the night.
Okay. Let's see. What are you using to hold the veneers in the mouth during the initial check before the cementation process? So try-in wise.
Just water.
Okay, thank you.
Just a few drops of water or saliva, and you can put it on, because when the patient just put the tongue over the teeth, and you can press slightly, and that will be like a small glue to the tooth. So you can use the saliva from the mouth and ask the patient to move around with the tongue, and then to place. It cannot be dry. For drying, it cannot be dry. It can be moist. So just water or saliva from the mouth.
Okay. Do you cure your bonding agent and flowable at the same time?
Sometimes yes, sometimes no, because the problem is when you cure the bonding and you not do it appropriately, you not dry away, and maybe you have a thicker layer of the bonding, then you will have a problem with put on the same veneer up, because you will not have the same position. So I think it's much better solution that you put the bond and the flowable composite at the same time, and then you glue it all together, because you don't have a problem in that time with the thickness of the bond. Because if you light cure the bond, it can be a little bit thickness, and it can be up to the 0.1, 0.2 millimeter, because if you don't dry it very well.
Okay.
This is the main problem when you're doing bonding before curing, before using the composite to cure it, and you cannot put at the right position. And you don't know where is it, because it's so tiny, and you have to find it. It's a big problem.
What if you have heavy proximal contacts? Would you do interproximal reduction?
If I have the very heavy proximal contact, I will skip that. If I could, I will skip that.
Okay.
I will not do that.
Okay.
Maybe together with the posterior part, but now you have to look the whole occlusion. You cannot just look for the just part. Or you can try, and if it's fell down, you can explain to the patient. But it's very depending of situation what we have. It's just what we have if we have. But the problem is also situation on the posterior part. The posterior tooth can cover all this or not cover all. I don't know what. It's depending on the case, from the case to the case.
Okay, thank you. If you seat the veneers incorrectly after curing, what is the best way to remove them?
Jump through the window. Drink tequila. Yeah. Then you think better.
Yeah.
What is the best? What is the best? You can remove it to cut it, and you can cut it very slowly, and or you can polish it, or you can use the airbrush also. Sometimes airbrush is very nice to remove with these particles, with the aluminum dioxide, and air abrasion, not airbrush, air abrasion is very good to remove, because you can control it, but also you have to. Sometimes with sandblasting, air abrasion, whatever they call it, you can go even through the enamel, and this is where the biggest problem, when to stop. So maybe it's, sometimes I use 3M Soflex to cut it smoothly. But first I can cut with a polish material, just to make a small cut through the tooth, and then to try with the probe to destroy it. And when you destroy a little part, you can continue to polish it and remove. Also, very slowly. And so many patients you have.
Okay. Since you're using flowable composite as a cement, what are the brands you prefer?
The brand you can buy it depending. It's different situation in Croatia, in the States, in Europe. Most of all, what I used that was GC material.
Okay.
GC material because I tried the 3M, I tried the GC, I tried the Foco, and when I start before that, I put it on the tooth and I light cure it, and I find it that the GC was more opaque than the others. What I needed there. So what you can do before, you just put the material on the tooth, 2-3 different type of material, put on the tooth, and then you choose the choice of material what you can bond it on, because you will see in that moment during the tooth what you have, and during the prosthetic what you get from the laboratory, and you can decide at that moment what you can use. This is the best way, because to say this material is better than the other one, I don't think so, because today's raw material is good, and depending in what situation you're using that material, this is most important.
Okay. If you're doing veneers from canine to canine, what is your preferred cementation sequence?
First incisor. As I said before, first incisor, you have to put incisor in the right position, because the problem is if you if you don't have in the right the incisor in the right position, you will have the problem with everything. If you start the canines and come to the incisor, maybe you don't have the enough space. But if you come to the canine, nobody will see if you move half millimeter distally the canines. But if you move 0.1 mesially, or if you don't put in the right position, just parallel with the abscess, and they have to be just to continue with the nose and the straight line. The middle line have to be straight. Not any angle cannot be in the middle line. So you have to put in the right position. If you put in another way, you can be big problem. You can be in big problem.
Okay. And our last question, could you explain to the young dentists what a Geller model is?
The Geller model, it's a perfect model when you can, the technician made a Geller model that you can move the tooth together with the root outside. And then you have the right position, and then you have, like you extract the tooth in the mouth, and you can put it back. This is the Geller model. And this is the better way, because sometimes when you do veneers, you can put it out and put it on the tooth. You can just prepare on the tooth. For example, you have here, and you can prepare, and then you put that tooth inside, and you can see how it fits. When you have the model without Geller, sometimes you cannot, where is the margin, where is the problem, and how deep you can go undercut. This is the best way to do the Geller model is best way for to do the veneers and also the other prosthetic part. For
well,
me.
Thank you again, Dr. Starčević. You've spent 90 minutes with us. We really appreciate that. We're going to have you stop sharing your screen. I'm going to share my screen with upcoming webinars and how people can register. Keep in mind the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series is free. You do not need to be an AGD member to join. So
I want to thank you for the invitation. My pleasure was to be part of this. I wish to all of you who is watching it and all the people in Croatia and in the United States along the world that we come from this situation better and better, and big heart from the Croatia to the whole team, dentist team in the US.
Thank you very much, bud. Appreciate you. All right, Val, can you stop sharing Dr. Starčević's screen for me? Yes. Oh, there we go. We're good to go. Thanks, guys. All righty. We'll just bring up what upcoming webinars we have. Keep in mind, you can use the QR codes on any one of these slides to get to the registration. If that QR code isn't working for you for some reason, the Washington, go to the Washington Academy of General Dentistry website. That's washingtonagd.org, and you'll be able to get registered. Thanks again to our presenters. They are doing these webinars for no honorarium. We appreciate them spending their time and sharing their expertise. Coming up here at noon, we've got Dr. Yassine as joined by Dr. Steve Rasner. They're going to talk about basic surgical and extraction skills as it relates to implant dentistry. So if you haven't registered for that yet, you can do so easily by going to the washingtonagd.org. These webinars are being recorded. You can see them within probably the next day or so at YouTube. Go to Washington Academy of General Dentistry, and that should get you to our YouTube page. And I think there's about 20 some videos there. Not all of them are webinars. Hey, tomorrow we've got Wheel Media joining us. What marketing should you be doing during COVID-19? Ian McNichols joining us. Pleased to have Janice Hurley that's going to give us some leadership skills tomorrow as well, so we can go back and try and get back to business as usual. Taser Suleiman, he's a materials expert from the University of North Carolina. He's going to be speaking on bleaching. And then Dr. Michael Fling, you don't want to miss this presentation. He's going to be specifically looking at contours and shape of anterior teeth with some drawing exercises, etc. So that's going to be a good one, especially for you young dentists out there. Everybody wants to talk about digital smile design. Hey, you can do a lot of dentistry analog. You don't need a computer to do this. So C verifications will go out via email in the next day or so. Look for an email from the University of Washington Continuing Education Department. It should be in PDF format. We advise you to hold on to those CE certificates just in case there's any issues down the road with reporting to the Academy of General Dentistry for your transcript or your local licensing boards. Thanks again to our sponsors, University of Washington School of Dentistry, Comet USA, Pierce County Dental Society, Snohomish County Dental Society, Seattle King County Dental Society, the Canadian Academy of Restorative Dentistry and Prosthodontics, let's see, Comet USA, Patterson. I think we've covered them all, but if I missed one there, I'm sorry, guys. And again, welcome to our friends in Texas, Arkansas, and California AGDs that are joining us. Appreciate it. And with that, we're going to sign off here for a few minutes, and you'll be able to jump on the next webinar at 11:50 Pacific Standard Time. Thank you to our Executive Director, Valerie Bartoli, our panelists, Gary Hayamoto, and thanks for myself, Timmy Hess. Take care, and we'll see you at noon.